actually more digital is our digital partner.
We are live.
In 2 minutes, we will start the session. Yes. So should I start the session? No?
Yes, you can start.
So, good evening all. This is our case meet 40. It's a TIVA tactical approach, drugs and updates. Today's stalwart is Dr. Tushar Choksi, sir. He came from all over Gujarat. Sir is working in Vadodara region, and he is a consultant private practitioner. In our word, is a freelancer anesthesiologist for most 20 years. Sir is actually one of the best thing I want to share with you. Sir is on editorial board of IJ. So it's a very nice thing, because today only I learned that IJ is granted.
Not able to hear you. You have to unmute. Satish. Satish, you have to unmute you. Hello.
Am I audible?
Yeah,
Hello?
now you are audible.
Am I audible, sir?
Okay.
Yeah. Okay.
Yes, you are also audible now. Hello,
You can.
Sachin.
Yes, sir. Sir is a consultant private practitioner in Gujarat, Vadodara. Sir is having 32 years of experience. Sir is mainly area of expertise is total intravenous anesthesia, opioid-free anesthesia, and non-opioid regional anesthesia. Sir works in neuro anesthesia, lepro anesthesia, and ENT, pediatric, and
Pain specialist.
Voice is cutting.
Hello.
I think
digital people.
Dr. Sajjan is having some internet issue.
Connectivity issue is
it's
there.
my problem, or it's on
So it
No,
is your
from
problem.
on
your
your
side
side?
there is a problem. Okay, nothing
It's
to
my
worry.
side.
Yes. I think Dr. Tushar, sir, you can start.
Now I want to share the
Yes,
screen.
yes,
So I want to
Yes.
share my screen.
Yes.
You can share
Yes,
now.
sir. You
Sir.
are now on.
Okay.
No, you are.
Okay.
You are
Can
the
you
screen,
see?
sir.
Can you see my slides?
Yes.
Yes.
Okay. Now, so friends, I'm Dr. Tushar Choksi, working in Vadodara, and I'm especially thankful to ISA Nanded branch for giving me the very good experience and opportunity to share with my experience of TIVA. This is my 64th same topic lecture in all over India and all over world. So I'm very happy to share all these things, and every time when I'm giving this lecture, I'm very much delighted to give this my talk. So just second slides. Can you see my second slides? Hello?
Yes.
Okay.
Yes.
Now, my topic is TIVA practical approach and updates. Now, before starting my lectures, I will give all the glimpses of TIVA and TIVA TCI. Now, the TIVA TCI is also going very much prominent in all over world. So that is a target control anesthesia. TIVA is a total intravenous anesthesia, and the new term, TIVA is a broad term like anesthesia. So anesthesia is divided into so many subgroups. So like TIVA is also divided in the TCI TIVA, without TCI, clad anesthesia, such like that. So I want to ask the audience poll who are attending this lecture, how many of you are giving TIVA and TCI TIVA? What is your definition of TIVA? what is your experience of TIVA, and will you give TIVA in your practice? I think I presume all this question I am asking to all the audience in all over world and all over India, because the TCI TIVA is coming a very prominent way in the India, and I had conducted 6 workshops till now on TCI TIVA and TIVA. So people are already giving TIVA, but they want to learn about TCI TIVA. So this today's lecture is a whole glimpses of the TIVA, TCI TIVA, CLADs, drugs, updates, and everything, how practical it is given. So coming to the my lecture highlights, my lecture roadmap is, I will give the history, definition, types of TIVA, indications, advantage, disadvantage, TIVA drugs and TIVA drug combinations, methods of giving TIVA, like people are giving with syringe infusion pump, target control infusion. I have developed my own infusion that is also called a TCI infusion, Tushar Choksi infusion, and closed loop anesthesia, where you do not have to worry about this total intravenous anesthesia, just the machine will take over. TIVA in different groups of the patients like pediatric, geriatric, ASA3 and obese patient. Surgical procedures which we are doing in, which surgical procedures we are doing in TIVA. TIVA checklist, what you will remember, and monitoring, how you monitor, and TIVA updates with TIVA apps also. Sometimes apps also we are taking advantage of this Android apps and iOS iPhone apps. Then future of TIVA, and what is my take home message and my verdict on TIVA, and what is your opinion about using this TIVA. So if I will start the history of TIVA, then people are asking that anesthesia is 175 years old, but believe me, even older than this is TIVA. TIVA was given in 1656 by the IV injection of opium in the dog. So it was an IV anesthesia in Oxford. And then in 1665, 1872, 1905, 1921. And the landmark year came in 1936, where the pentothal was given in the practice of anesthesia, and it was called a total intravenous anesthesia, because in short general anesthesia we were using this barbiturates, induction agent. Then ketamine came in 1962, propofol came in 1977, remifentanil 1996, then dexmedetomidine came in 1999. Then remimazolam is a new compound, came in the 2022. That is a combination of opiates and benzodiazepine. I will come over this molecule also. And recently, in third phase of the trial, the China has invented the ciprofol. That is after propofol. That is like atracurium, cis-atracurium, then propofol, cis-propofol, and ciprofol. So in 2022, it will be invented, and it will be in market within this next Diwali. So these are the drugs we are giving in a timeline history of this. So this is the IV anesthesia history timeline from 1930 to 2005. Almost last 100 years we are giving TIVA, but now the TCI TIVA, target control infusion, is also coming in a big way by the so many companies with the pumps and everything. I will have a few slides on that part. You will come to know, and you will be tempted to give even target control anesthesia. So my definition of TIVA, see, there are myths and misconceptions in all over world, all over India. Okay, what is total intravenous anesthesia? So definition is, it is a technique of general anesthesia which uses a combination of drug given exclusively by the intravenous route without the use of inhalation agent. That is called gas anesthesia, including nitrous oxide. Remember nitrous oxide, but here oxygen, compressed air, and helium are the exception. People are also asking that TIVA is used only for the induction period. No, it is not like that. TIVA is used in induction and maintenance both the way. So it is called total intravenous anesthesia. And TIVA is becoming popular since last 2 years because of the corona period. And there is a re-emergence of TIVA in this COVID time. And I had written a very good article in Indian Journal of Anesthesia. If you go to re-emergence of total intravenous anesthesia in COVID time, it's a very good article. And if you go, then you will find everything about TIVA, how it was given, and why TIVA was used in COVID time. Because gas was gives always side effect, like gives always side effects, right? So what are the types of TIVA? Types of TIVA is also one of the things you have to consider, that TIVA is given with endotracheal tube, without endotracheal tubes, with supraglottic airway, without supraglottic airway, with nasal airway, with oral airways, and without these also we can give this TIVA also, total intravenous. So TIVA can be given by endotracheal, people have here also myths and misconception that total intravenous anesthesia means the drugs is given to the IV line and forget about this. If you intubate, then it is called a total means IV inhalation anesthesia or total like other type of anesthesia, but it is not like that. Here the definition itself says that if you are using only a volatile agent, then it is called a balance anesthesia, then it is called a inhalation anesthesia. But here you are giving only total intravenous anesthesia, whether you are using any airway instruments or not. So what are the TIVA indications? Like anesthesia in almost all surgical procedure, like airway procedures, post-operative nausea and vomiting patients, means prone to that, daycare surgery. I'm giving all the patients to my anesthesia practice now, TIVA. I'm doing TIVA practice since last 20 years. And now I have omitted nitrous oxide, then this narcotics, and even all these benzodiazepines only also. So my technique of TIVA is now off TIVA, off pure pre-TIVA. So anesthesia in non-operating locations where inhalation anesthesia is difficult, short procedures like CT, MRI, cardiac catheter, and trainee teaching. People will be trained like in this. Patients with anticipated intubations and extubations. Suppose patient have a locked jaw and you want to do some procedures under ketamine anesthesia, you can do that. Malignant hyperthermia. Here volatile agent causes much more malignant hyperthermic or other way. So the TIVA is very good alternative. Remote locations. You can give TIVA even in your office procedures like skin clinic, ophthalmic clinic, then even daycare procedures of cosmetic surgery like that. Neurosurgery and neuromonitoring and neuro TIVA is coming as a separate branch of TIVA. That is a sub branch, like a DM neurologists are doing now exclusive TIVA in their practice, and they are using a TCI TIVA. Even patient's choice, even transfer of the anesthetized patient between environment. Something like if you are transferring from one hospital to another hospitals and patients is under GA, then you can transfer with the TIVA only. So these are the TIVA indications. And TIVA advantages are basic requirement of the TIVA for giving TIVA is, except for a slight prick in the arm, the patient is unaware of having an anesthetic, no mask over the face, no sudden concentration of gas or vapor, no risk of malignant hyperthermia, very low incidence of delirium, less chances of emergence phenomena. It avoids the distension of air-filled spaces in the body, so better operating condition for surgeon, because here you are not using the nitrous oxide. There should be no smell of any volatile agent. Like at the end of the day, when we are giving volatile anesthetic like isoflurane we were using, so we were tired up. And we were having, suppose we are going to home, then people were telling our relatives or our family members, okay, there is a smell from your body. So these are the things which are not there when we are using TIVA. Even better preservation of the cerebral auto regulations, reduce stress response. Stress response is reduced of our side because TIVA is become familiar with, anybody can give now. Patient wakes up like it's from natural sleep. Like dexmedetomidine is the newer agents, which are the most ideal anesthetic agent. They are coming in the pipeline. So when we are waking up from in the morning, then this type of way patients also wakes up in the after anesthesia. There is low spionage. So extubation eras means enhanced recovery of the surgery even after extubation is also without PONV, means post-operative nausea and vomiting. Least room operating room pollution. Here the scavenging systems are not required when you are using only TIVA. In my 2-3 theaters, I have removed even scavenging system. So I am very useful for that. In war situation, ambulance transfer and unexpected conditions, we are using, suppose I had a incidence of like that. See, when there was a Iran and USA war, at that time in the wounded soldiers were given anesthesia in the midway of the this ship where they had given ketamine anesthesia. Hello?
Yes.
Oh, at that time also, my slides are something, some problem is there. You can see it, but ne? So yes, in war situation, ambulance transfer and unexpected condition also TIVA is good. So TIVA is favorable to almost all body systems central nervous system, immune system, cardiovascular system, post-operative pain, older patients, oncology surgery, gastrointestinal system, and even renal system. So it is favorable to all systems where you have everything about this. Well, so TIVA can be given to each and every patients with this, all these systems. But coin has two sides. So there is some disadvantage of TIVA also. Like pain on injections. Injection is irreversible. Disposable may be costly. Incidence of awareness if not given. Undetected errors in delivery system. Environmental effect of plastic waste. Not having another apparatus to carry on the TIVA. Even if we are not finding the vein, then also we cannot give TIVA. Possibility of not finding the vein, shallow respiration, risk of bacterial contamination. Here, all the bulbs, suppose like in foreign countries, there are ampoules of the propofols are available, but in Indian situation, the pharmacological companies are producing bulb of the propofol. So there are repeat of taking the injections and multiple punctures in the this bottle. So there is a risk of bacterial contamination. Cautions in prolonged procedure of obese patient. Here I had in maximum in my lifetime 7 hours of TIVA I had given in one of the sex reconstruction surgery with very nice way. So 7 hours up till that I had given very good way. And in difficulty in knowing blood concentration of this this anesthetic agent. So all these TIVA agents, TIVA completes the anesthesia circle, what we have learned in our anesthesia residency program, that is called hypnosis, sympatholysis, amnesia, hemodynamic stability, immobility, and neuromuscular blockade. Everything can be given by TIVA agent only. So which are the TIVA drugs we are using in our armamentarium? These are the propofol, ketamine, etomidate, narcotics, benzodiazepine, dexmedetomidine, muscle relaxants, and other adjuvants are easily available in almost all theaters and outside OT. So what else you require in your armamentarium? All the weapons are in your theater. And all these drugs, beauty is that all these drugs can be given to any subset of the population, from pediatric or neonates to geriatric patients, and easily titrable dose in even TCI dose or this MCI dose, whatever you take. Now I am going to give you some of the glimpses of all these drugs, very one slides, and these are the infographics of the drugs which I have created in all over India first time. These are the drugs which I have compiled since last 2 years, and almost 65 drugs were invented. 65 drugs were invented in our 175 years of the invention of the anesthesia, and in which 45 drugs are in use, and out of this TIVA is 25 drugs. So this is the list of, this is the infographics of the TIVA drugs. And what is the ideal TIVA drug? Rapid onset of the action, rapid and predictable recovery, potent and lipid soluble. It is also a water soluble to minimize the toxicity associated with the solvent. It should be stable in any solution, whether it is ringalactate or any fluids containing dextrosalines or normosaline. Chemically compatible with other drugs. It can be combined with other drugs. No perivascular sloughing if extravasated like propofol. It should be titrated in the subcutaneous way. Not absorbed by the plastic, does not promote bacterial growth, devoid of any adverse reaction. Sorry, low cost, and most important, it can be mixed with the other anesthetic agent. So without any complications. So we can mix 2 or 3 drugs combining with the TIVA agent, which I will come to another slides. So these are the TIVA tool drugs box like propofol, ketamine, dexmedetomidine, dexamethasone, lidocaine, clonidine, magnesium sulfate, diclofenac sodium, paracetamol, all muscle relaxants and opiates. These are the things we are using in our TIVA practice. So which are the IV anesthetics? I will give you some glimpses of one by one all these induction agent, adjuvants and other narcotics. Propofol, I consider it is a prince of our kingdom, TIVA kingdom. So it's a prime drug in all TIVA practice and combination. Initially, TIVA dose is 2 to 2.5 milligram. And if you are using TIVA mixture, then it is dose is 1 milligram to 1 milligram per kilogram IV. And co-administration of propofol ramifentanil is in target control anesthesia is the highly effective and it constitutes the ideal total intravenous anesthesia. And believe me, it is a most ruling combinations in the TCI TIVA combinations in all over world, and it is accepted. Here, remifentanil is not available in our country, but within 2 months, Neon and Troika and other companies are coming with the remifentanil within soon. And here, right side, I had given a TIVA dose and TCI dose with the anesthesia depth, how it is given, infusion and target control. And these are the propofol infographics I have created in my infographics book, and I will share with the Nanded branch, and you will get it after this lecture. Now, second drug is ketamine. Ketamine is, I consider it's the most popular anesthesiologist drugs across globe since 50 years because it is a Brahmastra. One survey was done just 2 years back by some of the anesthesia groups in Facebook, which is the most popular drug in the anesthesiologist armamentarium. So 49% of the people tell that ketamine is the most popular drug since last 50 years. So it is a key role and main drug in TIVA, best analgesic, amnesic, and opioid sparing effect. And it has got an anti-hyperalgesic and anti-tolerance effect. So it is best given in an adjunct with combining with the other induction agent. So it is the only intravenous anesthetic with hypnotic, analgesic, and amnesic property. It produces rapid hypnosis with profound analgesia. And dose is 0.5 to 2 milligram in a wide range. It can be mixed with any type of anesthetic and narcotic agents like ketamine with midazolam, ketomide, ketamine with propofol, ketamine with dex, ketamine with the etomidate also, and one of the established drugs in the TIVA mixture. This is ketamine infographics. Now coming to dexmedetomidine. Dexmedetomidine, I consider it's a very recent drug which was invented, but it was again came in the pipeline of the use, and it is the most ideal drug available just now in India. It is alpha-2 agonist. Dexmedetomidine has hypnotic, sedative, and analgesic property, and is estimated to be 7 to 10 times more potent than clonidine. Believe me, I will suggest every anesthesiologist that you use these drugs very frequently because it's a very good drug, and you will switch over your anesthesia from propofol to dexmedetomidine, and with combining sometimes in the ketamine in pediatric patients. So it is a most ideal anesthetic agent with all the properties of anesthesia. It has got a opioid sparing effect. Dexcat ketodex combination is a very good pediatric TIVA and opioid free anesthesia. Patient will be sedated but arousable. Like when we are sleeping in the midnight, at that time when we want to go to washroom, then we are waking up. After doing washroom, then we are coming back to our bed and we are again sleeping. So there is no So this type of the awakening and sleeping is there when we are giving dexmedetomidine anesthesia. Patient will be sedated, but suddenly it is arousable. So it is the beauty of this sedation. They may quickly return to sedation. So it is called a conscious sedation or natural sedation. See, this drug is becoming widely popular in all part of the world in all anesthesia practice, and dose is 0.5 to 1 microgram per kilogram. Maintenance infusion is generally initiated 0.6 microgram per kilogram per hour. That is for when you are giving as a maintenance dose in TIVA practice. And in TIVA, pediatric TIVA, I have told this is a ketodex. That is a good combination to give in the pediatric TIVA for all this NORA situation. And this is dexmedetomidine infographics. Those who are not using dexmedetomidine, I have urged with my poem, hey buddies, I am dexmedetomidine. My pet name is Dex. I am your complete friend to play with you in all games like IV, IM, oral, spinal, even nasal also. But my favorite game is intravenous with all stages, sedation, hypnosis, analgesia, anesthesia. I love to play with small babies to old age players, but during playing with me, be careful. I am very delicate and fall down with the weak players. I can also play in the indoor stadium like ICU patient continuously for 48 hours. I am always available to play with you and allowed me to play with others. Let us play and enjoy with me. Don't think like me, though I am a new player. So my again advice is that when you are using propofol, those who are not using dexmedetomidine, start using dexmedetomidine in your practice. And the beauty of this ketamine dex, whenever you go to your pharmacology book and whatever the routes are mentioned like IM, IV, sub-Q, nasal, then drops and whatever may, ketamine and dexmedetomidine can be given by these routes. So what else you require? Etomidate. It's a very hemodynamically stable drug, cardiostable drug. I reserve it for my cardiac, non-cardiac surgery for the cardiac patients. It's excellent cardiovascular drug used mainly in hemodynamically compromised patient as a TIVA induction agent. Sedation to induction 0.1 to 0.4 milligram per kilogram body kilogram dose is given, and I'm using hardly 1 or 2 cases in my full 1 month of my anesthesia armamentarium. So it is a reserved drug for this. This is etomidate infographics. Thus consider that etomidate can be combined with the ketamine also. Now opioids. There are 2 opioids we are using, but in India fentanyl is available, remifentanil is not available. Fentanyl in bolus is 3 microgram per kilogram 30 seconds, followed by 2 microgram per kilogram per hour 30 minutes, then 1.5 microgram, then 1 microgram till the skin closure, which I am using like that way. Remifentanil is available after 2 months, and we will be blessed with this agent when we are using TCI TIVA. That is 1 milligram, available as a 1 milligram vial, 2 milligram vial, 5 milligram vial, and initial dose is 1 microgram per kilogram. And in TIVA maintenance, 0.25 to 0.5 microgram per kilogram, and post-operative, we have to reduce the dose by 1/10. So these are the fentanyl infographics. This is remifentanil infographics. I will have to say some words about the ramimezolam. This ramimezolam was invented by Japan Peon Company, and it was in 2020. It is available all over part of the world except India. It is available in USA by Bifeo name. In China, it is Roima. In Europe, Canada, South Korea, it is under Aptimeda. The beauty is that it has got a benzodiazepine with opioid property, and it also can be combined with there are so many papers came in the journal. Then it's like a switch on and switch off anesthesia, like we have learned in 1997 when propofol came in the market. So it's a very good agent. When it will be available, our TIVA practice will be like in golden period. Now, some of the adjuvant drugs we are using, like midazolam, I am not using these drugs, but it's a very good agent for the TIVA as an adjuvant. It is given in the 0.05 milligram per kilogram, and administration of midazolam reduce the induction dose. But remember one thing, in one patient at any time, don't give more than 10 milligram of the dose. This is midazolam infographics. Magnesium sulfate. This agent, it's a versatile friend for the anesthesiologist. I will tell why I am calling. I also called it is a intravenous oxygen for the anesthesiologist. Why? Because it has got a 32 effects in the anesthesia practice. That is antihypertensive, bronchodilator, antiarrhythmic, analgesic, anti-seizure, anti-severing, anesthetic adjuvant, antacids, and mild sedatives. And it is useful in given in patient with the total intravenous analgesia. In my practice, in each and every case, even it is spinal, even it is blocks, or even it is a short cases, I give magnesium sulfate in a dose of 30 milligram per kilogram body weight maximum, and less 1 gram. And you know that this 2 ml ampule containing 1 gram, it is available as a Magnion or whatever the company, it is only 10 rupees. And it reduces the propofol dex atracurium dose, and very cost effective. You will just blinking your eyes, you give this agent without anything. The only thing you have to remember that whenever you give this agent in your practice, you give pre-operatively, and when you are giving this agent, then this drug, then tell your patient that you will feel that some of the warmthness, temperature feeling of your body, means garam lag raha hai sharir, aisa lagega. So these are the 32 clinical effects of the MGMSO4, and this is the MGSO4 infographics. Second adjuvant is dexamethasone. Dexamethasone is also almost all 99% of the cases I am giving. It's used widely in TIVA as an adjuvant. Now, when you know as an anesthesiologist, it is as good as the antiemetic effect like ondansetron. So it is anti-inflammatory. It treats the post-operative nausea and vomiting. It suppresses the inflammation, good analgesic effect. If you give 8 milligram of the Dexona to any patients, irrespective of age, disease, sex, it is a good for you in TIVA practice. So good quality of recovery and early discharge in patient from TIVA anesthesia. See, people are asking me sometimes that This Dexona is increasing the sugar level in this surgery and during anesthesia in diabetic patient. But the papers and proven part is that it increase only 12 to 20 milligram of the sugar level in one dose, like 6 to 8 milligrams. So nothing to worry. You just give this. Even surgery stress and anesthesia stress also will increase the sugar level in our patient. So without even diabetic patient also, I am giving 6 milligram per kilo, such 6 milligram bolus dose. So it is a dexamethasone is a very good friend for the anesthesiologist. Dexamethasone, this infographics, best companion for the anesthesiologist. Third drugs, my very favorite drug is lidocaine. It has got an analgesic, anti-hyperalgesic, anti-inflammatory, reduce the opioid analgesic consumption, anti-arrhythmics, improvement in patient's outcomes, and decrease the erosion and droplet during the extubation. So these three drugs I will recommend for you, that you give dexamethasone, magnesium sulfate, and lidocaine in your practice. This is intravenous lidocaine. I called it as a magic drug. See, so suppose in your body everything is disturbed, like all systems are disturbed, your extubation, intubation response is disturbed, then everything, your heart is irregular. If you give at least 1 milligram per kilogram lidocaine in your anesthesia time, then everything will be settled down as a, like it's a magic. Everything will be settled down, like your bronchospasm, arrhythmias, your other things and pain, everything. So I called it is a magic drug. Another two drugs, paracetamol and diclofenac sodium, NSAIDs, I am giving patients regularly in my patients, even it is a pediatric patients or geriatric patient with the dose regimen. Paracetamol and diclofenac sodiums are preemptive analgesic. Both has got a opioid sparing effect. In paracetamol, leading dose is 30 milligram and maximum is 2 gram. Very innocent drug. In pediatric also, I am giving very frequently. Diclofenac sodium is also, I recommend you give 1 milligram to 1.5 milligram per kilogram IV slowly, and caution with the renal, hepatic, pulmonary, and heart failure patient. The thumb rule is that always give both the drugs before surgical incision to inhibit prostaglandin receptors. Why? Because once the surgical incision is there, and then if you give these two drugs, then there is no effect. 50% of the prostaglandin inhibitions receptors are released, then there is no effect of these two drugs, because where they will act. So before surgical incision, you have to inhibit these PG inhibitors, receptors. This is paracetamol infographics, diclofenac infographics, and in my last drugs is esmolol. Esmolol is a beta blocker. It is a opioid sparing adjunct, gives central anesthesia. When these drugs came in the market, I have stopped using sodium nitroprusside and other beta blockers because it's an emergency friend for the anesthesiologist. This is the only drugs which is causing bradycardia and hypotension. So in laparoscopic surgery, in ENT surgery, and sometimes in vascular surgery, this is the most good agent. And the thing is that it gives central anesthesia. It can be given up to the age of 2 years of the old age for the anesthesia. Even pediatric patients up to 2 years of, after 2 years also we can give. So it is a very good, and it is given improve the post-operative pain and reduce the opioid requirement. So I will recommend these drugs, and very short acting drugs. So you don't worry about this. It's a very innocent drug. So it is esmolol infographics. Now the TIVA drug combination. I am a man of combinations. So what to understand before mixing any drugs for anesthesia? We have learned in our anesthesia armamentarium and residency that anesthesia triangle. The triangle is like a prism. They consist of hypnosis, analgesia, and relaxation. Whatever the drugs are entering in this prism, they causes pharmaceutical, pharmacokinetics, pharmacodynamics, and thermodynamics combinations. So the rule is not mix with more than 3 drugs at a time. Hello? And there is a very good article came in the Coleman Journal of Anesthesia. Which drugs can be mixed with which drugs? Red is not compatible, green is compatible, white is not tested. The hidden world of the drug interaction in anesthesia. Here, if you see that propofol can be mixed with all drugs except some of the relaxation. So conclusion is drug interactions are the cornerstone, and you have to understand the pharmacology, pharmacokinetics, pharmacodynamics of each drugs when you are combining, whether they are doing some spectrometry method, crackling, gas bubbling, effect, how many hours it will last. like that. Now, those who want to use TIVA, so I have created a one TIVA kingdom where king and queen are the queen. We are the king of our TIVA kingdom. Prince is the propofol. Ketamine index are the first and second supreme commander. Fentanyl and remifentanil is our commander. And other are soldiers like magic soldier, reverse reserve soldier, oxygen soldier, like that. So whenever you want to use these drugs in your TIVA practice, then you ask yourself, okay, which drugs should be combined, which drug in maintenance, what you want to give, with induction, what you want to give, in pediatric also what you want to give. So in TIVA here, king will decide. We will decide in the battle of military that TIVA whom to send in alone or in combinations. And in TIVA, Prince is the most common warrior. Propofol goes in both TIVA and TCI TIVA. It is the most common drug we are using in this world. In TIVA maintenance, either propofol, ketamine propofol, or dexketamine, or whatever, alone propofol or alone dexmedetomidine. So Prince with one or two supreme commander and other commanders are the best military for the TIVA maintenance. In pediatric battle, pediatric TIVA, in absence of presence of the Prince, like if you are not using propofol, then dexmedetomidine ketamine combination is now this dexket. Pediatric TIVA, pediatrician, more than 500 articles are written in the journal. So my request is that now you omit using propofol ketamine. Now you use dexmedetomidine ketamine in your practice as a 1 milligram and 1 microgram combinations. So which drugs are combined? Like KPD. KPD is a ketofol, ketamine, propofol, and dexmedetomidine. Ketofol, ketamine, propofol, ketodex, and dexket. That is ketamine or dexmedetomidine. FP or RP, fentanyl propofol or remifentanil propofol. Or in South, people came with the PDF, MDF, and ketomed combinations. So ketofol, I have told, ketodex, ketofol, ketomed, and ketoetomidate. These are the drugs combinations we are using. So rule is that you use 1 milligram or 1 microgram, 1 milligram or 1 milligram in combinations. So when you are using ketofol, then the combination should be 1 milligram, 1 milligram. When you are using dexket, then 1 milligram, 1 microgram. So everything will be combined. And I have developed my own 10 years back KPD TIVA, that is ketamine, propofol, dexmedetomidine TIVA, and there are more than 5 papers are in the journal now. So mixture of 1 gem, 1 dose of for TIVA, that is 1 milligram, 1 milligram, and 1 microgram. And combination of all these drugs permits lower dose of each individual agent TIVA and reducing their adverse hemodynamic and respiratory effects. We can use as a bolus, maintenance, and short cases, less than 30 minutes. The excellent analgesia and anesthesia is the beauty of these combinations, because it decreases the dose of individual. Each drugs mimics each other's effect. Like ketamine causes hypertension, dex causes hypotension. Ketamine causes silagogue effect, and dexmedetomidine causes anti-silagogue effect. Like that. That gives stable hemodynamics. It gives decrease the airway complication, and there is a rapid recovery. In my all NORA procedures and even induction time, I'm using these combinations. Propofol fentanyl, propofol dose reduction is by 50%. RP TIVA, that is remifentanil propofol TIVA, most widely used TIVA combination in TCI in the world, where the propofol dose reduction is 50%. Now, how you give the TIVA? TIVA is given by either single drug or with combination of a drug, by single syringe technique or mixture of the drugs, or with only one drug, continuous IV infusion with single syringe infusion pump, and target control infusion. And lastly, it is automated drug delivery through closed loop anesthesia. But the most common thing is single syringe TIVA, no additional. This is without intubation, or when you are giving as a bolus dose, or when you are giving a short general anesthesia. No additional investment for TCR closed loop systems are required. Single syringe or pump are okay. Only one syringe is used. Combination of the drugs are used. Short procedure can be done. It can be practiced in low anesthesia departments or outside the operating room, and low anesthesia resources, like that. Manually control infusion, MCI and TCI. TCI is target control, MCI is manually control. Manual dosing of anesthetic agent during TIVA. Here some of the TIVA apps will be infusion calculator, and everything will be helpful, which I will come in the next slides. Here it gives a with fixed infusion rate and with syringe infusion, with syringe or IV drip. Then this propofol manual infusion we were giving like Bristol regimen. Target was 3 microgram per ml. So loading dose See, when TCI was not there, at that time, propofol used as a Bristol regimen. How it was given? Loading dose is 1 milligram or 2 milligram. 10 milligram per kilogram for 10 minutes, then 8 milligram per kilogram per hour for next 10 minutes, then 6 milligram per kilogram per hour for thereafter, up till whatever 2, 3 hours, 4 hours surgeries. So these regimens people are still using. Now people are asking that propofol, can we dilute propofol in any solution? Yes, it can be diluted from the bulb or ampule. It is compatible and it can be diluted with 5% glucose, normal saline or DNS or RL. Commercially available is 1%, means 10 milligram per kilogram. The rule is that dilution should be 1 part of the propofol and 4 part of the diluent. So you should not dilute this lower than that. So how I was doing my propofol dilution? Take 100 ml of 0.9. When we are not using target control infusion, that's at that time when you are using manual control infusion, at that time you can use this method. Take 100 ml of 0.9% of NaCl infusion, remove 20 ml, add 20 ml of 1% propofol. So this infusion becomes a 2 milligram per propofol. Maintenance dose, my dose is 6 milligram per kilogram per hour. So in 65 kg patients, it finishes within 30 minutes. You can use within whatever the bulb, even 6 bulb, 10 bulbs propofol we can use. These are the total intravenous anesthesia sets are available in the world. Now target control infusion. Now whatever the workshop I am doing in all over India, nationally or state level, I am maximum giving stress over this target control infusion. So target control infusion is an infusion control to achieve preset drug concentration in the plasma or the effect site. Key components are 3. User interface, which enters the details and target blood concentration, software with the pharmacokinetics, pharmacodynamic model, and communication between the control unit and pump hardware. See here, when we were using manual dosing, at that time we can use more propofol, or without this our patients are aware or not aware, or how many depth of the anesthesia is there, we were not knowing. But by target control infusion, we have a set criteria at the plasma level or effect site level, and we can have an exact mechanism what type of the propofol exact concentration will go. So always finding out the TCI dose of the propofol is always lesser than the where we were manual giving. So there are saving of the propofol drugs and easy to use it. These pumps are available from 1.5 lakhs to 2 lakhs rupees in all over India. Now 3-4 companies came in the market. I'll give the, so 2 types of this TCI TIVA infusion models are available. One is specific drug model. So propofol, for propofol TCI model, for remifentanil this TCI model, even for ketamine, for dexmedetomidine are also available. So people recently in 2022, they have invented a general purpose model. That is Eleveld model, or one pump which combines all the drugs. When you are using same pump for the propofol, you can use this pump as a propofol TCI. If you want to use as a remifentanil TCI, then you can use as a TCI remifentanil. You can use as a dexmedetomidine. You can use a ketamine, whatever way. So these are the Acromed, Eleveld, BD, LRS, PKPD, SP, Medcaptan, B Brown available in India just now. People have invented in China and Europe single syringe TCI, double syringe TCI, and 3 syringe TCI. Here you can see there's one pump is for propofol, one is for remifentanil, one is for the relaxant. And he's the person who has invented this TIVA technique, modern, and he has used first TCI pump, that is deprefuser, for propofol in 1996. So clinical, see, these are the things which we want to learn in TCI: more predictable in onset, more predictable offset, and short time of recovery. Even this pump, whenever you give anesthesia, when there is a stopping of the surgery, and then your pump will tell you that in how many minutes the patient will come out from the anesthesia. Believe me, it will tell you that within 5 minutes and 6 seconds, the patient will be opening their eyes. That is the beauty of this TCI pump. It saves the nursing time, limits the need of antiemetic therapy, and allows the patients an early return of the work. I'm using frequently this TCI TIVA for my long cases. Now people have started recently, in this August only I found this article, that is pressure control sedation by TCI. Target control infusion is even used by the patient himself for the sedation in ICU or even post-operative period. This Glasgow people have invented. These are the different pumps are available for specific model. Marsh and Schneider for the propofol, Perfuser and Kataria for propofol in pediatric patient, Remifentanil, Minto, Mitre for alpentanil, GAPS for the subentanil. And these are the general purpose model. All drugs TIVA software in TCI. These all pumps are in one general purpose model pump. I developed my own infusion that is called Tushar Choksi infusion. I am giving without infusion TCI 3 styles. I usually give one KPD infusion, ketamine, propofol, dexmedetomidine in the dose of 0.5, 0.5, 0.5. Initially, I told you I using as a induction 1 milligram, 1 milligram, 1 microgram. Here, when I am giving as a infusion, as a maintenance, then 0.5, 0.5, 0.5. If I am using dexmedetomidine alone, then 0.7 to 1 microgram, propofol infusion 6 milligram per kilogram without TCI machine. Now, in India only, from PGI, Dr. G.D. Puri has invented closed loop anesthesia. He is the Indian anesthesiologist who has invented first time in the world automated total intravenous anesthesia. It is called a TIVA or a CLADS, a closed loop system. It is ideal means of automated delivery. Here inputs are drug and outputs are our monitors. There is in between there is a computer. The computer will decide by the input of delivery. See, drugs are given in the body by this infusion pump, and from the body output of all the parameters with this pump, these monitors, again the computer will decide how much dose to be given in the anesthesia period, either with the propofol or either with the remifentanil. So it's a vicious cycle. So it is called closed loop anesthesia, and when there is a blood pressure is low, when there is a light mode of the anesthesia, then drugs will be injected. And at that time, the depth of the anesthesia, if it goes 40, then drugs will be withheld like that. These are the things are closed loop anesthesia model, very complex model. Even people have invented eye control IP, robotic induced TIVA CLADS. So US FDA approved, and it is invented in Vancouver, Colombia, by Ansar Mino, pediatric anesthesiologist. And in some of the subset of the patients, I am very useful to give, very prone to give this TIVA, like pediatric, ESA3, geriatric, obese. Just few words about the pediatric anesthesia. Pediatric TIVA is very viable project. Here I told you about Dexcate or Ketodex truncation is very much popular. And propofol, ketamine, remifentanil, dexmedetomidine you can give and play an important role. As far as ever TIVA in neonates, because their centers are not developed. And the thing is that you have to remember that obese children are used for total body weight to calculate the dose. And here, when you are using TCI model, then you use Kataria or Perfuser TCI model. Even you can give geriatric patients. Geriatric patients are also very good agent, very good patients for the TIVA technique. Compared to inhalation anesthesia, their cognitive functions are much preserved in TIVA, and always starts with the low concentration infusion. Here my own rule is that, and I am telling to my resident also, whenever you start a TIVA practice in geriatric patient, then go low, go slow, and always follow. Means you use low concentration, give slowly drugs, because their one arm brain circulation is twice, thrice times than the normal patient. So that is the rule you have to follow. And here avoid hypertension during the anesthesia point of view. Multi-para monitoring oxygen is must during this. TIVA in obese patients. These obese patients are also very much laparoscopic obesity patients are for obesity patient for laparoscopic surgery. They are very ideal patient for me in TIVA. TIVA is an excellent method. I am using scoline in this patient because no relaxant technique is not advisable for the obese patient when you are using TIVA. Always give suxamethinium. Multi-para monitoring is always there. Oxygen is to be given in all TIVA patients. TIVA in ASA3 patients. Here also I can give low dose because see, the beauty of the TIVA is you can titrate the dose with your thumb rule, with your TCI, with your infusion rate, with your syringe, whatever way. But there is no specific protocol for the TIVA. Choose the most appropriate TIVA drugs, like patient is elderly or young, or patient is obese or non-obese. So my golden statement is surgical procedures done under TIVA is from OT to outside OT. That is the beauty of TIVA, because over the volatile anesthesia, from pediatric to geriatric, and from any surgical to medical specialty, you can give TIVA in your skin surgical skin office, Means when there is the skin specialist calling for wart removal under anesthesia in pediatric patient, you can give ketamine anesthesia, you can give dextrose anesthesia in his room only. The requirement is oxygen, suction machine, and some of the things, drugs. So we can do all the procedure. There are some checklists when you are giving TIVA. All anesthesia drugs, airway equipments, oxygen, multipara monitor must ensure no leakage from cannula and must. Patient's IV cannula is always visible during the surgery if possible. Syringes should be labeled. This labeling is very much near to my heart, because if the syringes are not labeled with my anesthesia card, then I'm always throwing away, because I never trust of my even myself, even my juniors or even my colleagues. So always label the drug. Infusion line should be checked every 15 minutes. Infusion set through which device dealer should have a lure lock system. You should have like a screw motion IV set. If this is used, I will recommend that you, when you have a good practice, then you buy this machine. It is available at around 2 lakhs rupees once in a lifetime. Then your practice is very good with the TIVA. So check all the electrodes when you are putting in the forehead. Check placement before and after surgery draping. And at the end, ensure all tubing IV cannula which had TIVA drugs by any method are flushed to prevent inadvertent boluses in the ward. Some of the monitors we are using in, believe me, as an anesthesiologist, we are the best monitor available in the world. I consider myself as the best monitor. Whatever the monitors will be invented in the world till 2050, I am the best monitor as an anesthesiologist. So this is the golden rule. So loss of response, visually anesthesiologist, loss of response to shaking and shouting, loss of hemodynamic response, absence of tachycardia or even bradycardia. And some of the machines are using where multipara monitoring is a routine, bispectral index, that is a BIS monitor, evoke potential when you are using a neurotiva, process TEG machine when you are going for this TIVA, null monitor, then entropy, or these are the monitors which are, these are the sister concern, one name or another name. So TIVA has become more popular, practical and possible due to main reason. First, the advanced knowledge of pharmacokinetics, pharmacodynamics and property of drugs such as propofol, ketamine, dexmedetomidine and newer short-acting opiates, making them suitable for intravenous administration. Second, new concept in pharmacokinetics modeling coupled with the advance of the technology of infusion pumps which allow the use of algorithms such as syringe infusion pump, target control, and then closure. And propofol with remifentanil seems to be dominating the TIVA. Some of the TIVA apps are this iTIVA, IV calculator, infusion calculator, anesthesiology. Then these are the TIVA textbooks available. This is the only TIVA textbooks available in the world by Dr. Absalom. That is available, the soft copy. I have that soft copy. I will again give it to this Nanded branch of anesthesiologist. So TIVA, in fact, patient friendly, surgeon friendly, anesthesiologist friendly, economically friendly, environmentally friendly, and productivity friendly. So what else you require? This is how it is used. TIVA will be a norm in future practice. Believe me, in 2020, 25 or 30, TIVA will be ruling all over the world with all anesthesia techniques. In future, auto TIVA through artificial intelligence and metaverse with the help of TCI and BC is viable. In 2030, you will heard that metaverse TIVA anesthesia, artificial intelligence TIVA anesthesia, robotic TIVA anesthesia, like that. Dexmedetomidine TCI model, this was invented in 2022. My dream is that when we have a vaporizer mounted on the anesthesia trolley, like that our syringe TCI pump will be mounted on the anesthesia trolley. So TIVA will be a norm in new normal. TIVA will rule on anesthesia techniques by 2030. So all in one TCI TIVA. You see this Sweden people and this Switzerland people have invented TCI and class both in a one syringe pump. And if you want to play something, one game on your TCI pump, then you can play with the same pump with the, like you have this joysticks and you can play in between your anesthesia also. And today we have this type of complex theater and complex machines, wires, gadgets, and everything with our on the head side. How we can use. So my dream is future anesthesia workstation in 2030, switch on, switch off anesthesia. There should be only one anesthesia station, like workstation, like cabinet, where there is only one button. One button will be sleep mode and awake mode. When you want to give anesthesia, then you put the patient on the asleep mode. When you want to awake the patient, then put switch on awake mode. And if in between, if you want to relax, then you can have a coffee vending on that anesthesia machine only. You can take the coffee also. So every monitor, vaporizers, and syringe infusion will be in the one cabinet only. Now newer drugs are invented like Remimizolam, Sugammadex, and 3 drugs are pipeline: Heptiva, Busitols, and Ciprofol. So think outside the box. Step in your comfort zone with the TIVA and TCI TIVA with safe anesthesia, safe surgery, safe patient, safe environment, and safe yourself. So total intravenous anesthesia is a viable and safe alternative to the inhalation anesthesia with lots of advantage over the better. TCI pumps and advanced monitor make administration of TIVA easy and precise. Manual control infusion using regular syringe pump can be used to deliver pre-calculated dose. And the newer intravenous hypnotic and analgesic agents with favorable pharmacodynamic properties have made TIVA more popular in wide era of varying clinical scenario and anesthetic demand. So don't think, just go with the TIVA. Don't think that when I will give, the patient wants more than gas anesthesia. So my question is, which steps you have reached? I won't use anesthesia. TIVA, I can't use TIVA, I want to use TIVA, how do I use TIVA? I will try to use TIVA, I can use TIVA, I will use TIVA. Yes, I have used. I want to first step that I use TIVA. Now I have created a TIVA Society of India Facebook group. You can join, you will have all the abilities and reading of all the journals, articles, and everything. And very soon we are going to form a ICIVA, that is the Indian Society of Intravenous Anesthesia. And there are different societies also available in the world like EuroCIVA, World CIVA, CIVA.ac.uk. In near future, we are coming at ICIVA, I told you. I love you, TIVA and TCI. And I write always in my slide, first my presentation slide, that I born with the TCI, TIVA or TIVA in my birth time. Thank you.
Thank you, sir. Very nice presentation and very nice presentation, sir. Thank you, sir. Thanks a lot from ISSD and Nanded.
Hello.
Hello.
Somebody speaking, but
Sir,
I'm not here.
Yes, sir. Sachin is not audible with because of his network
Sachin
connection.
is out of the range.
Thanks. Yes, sir. He's out of station today. Thank you, sir, for a nice presentation. We have learned a lot from your lecture today. Your some concepts regarding the TIVA are very good, and the recent advances which you have told right now, like the mixture of dexmed with ketamine and propofol, these are quite new for us, and
Yes.
shortly we have started using that. But the mixture you are told are very interesting.
Yeah. We have gone for the even pharmacological testing also. There is, see, if you are using in one syringe, how I am using also, I'll tell you. I am taking 12 ml of syringe. I take 10 ml of propofol, that is 100 milligram. Then 2 cc of ketamine, that is 100 milligram, and 1 cc of dexmedetomidine, that is also 100 microgram. So 12 ml of syringe, it causes 13 ml also, we can use it. So out of that, we are using 1 milligram, 1 milligram, and 1 microgram. So suppose this patient is having a 70 milligram of 70 kg weight, then we are using around 8 to 8.5 ml of this out of these mixtures. And believe me, these mixtures, when you are giving the patients, then patients are very stable in hemodynamically. And this combination gives a very good analgesia, good hypnosis, good relaxation, even some muscular relaxation without muscle relaxation. Then this lasts for at least 20 minutes. So in my all URS patients, when I'm using this technique, and after scoline, I just have to put a iGel, and this one dose for 20 minutes is okay for my URS, means urinary return endoscopic surgery. Even in colonoscopy, even ERCP, lesser dose is required, but excellent. And patient does not have, even you can use in ER3 patients very low, because each and every drugs are in a low dose. We are not giving propofol
Yes,
2 milligram, not in a. So this is the beauty of these combinations. And I use more than 10,000 patients, not lesser than that.
yes, yes, sir. Uh, Let me see if anybody has any questions or queries regarding this. Yes, up till now nobody has any questions. I ask the participants, if you have any queries, you can ask me.
Hello, sir.
I even see people
Yes.
are what? Okay, somebody is asking.
Sachin,
Sir, you are using your TCM method with RL. You are putting all things in RL and using the yeah. For what procedures you are using this? And
KPD?
can you elaborate on that?
Sachin, can you
no,
write
sir,
your
he is
question?
asking. Yes, sir. I will explain you. You are said that you are mixture keeping all the drugs in the ringer lactate 500 ml, and you are going to run it for a short period.
Yeah,
For
yeah.
which are the procedures? Yes. For which
All the
procedures he's
procedure.
asking?
ENT.
Yes.
See, I'm practicing in the ENT, lapro, then head and neck surgery. This
Okay.
year's mostly head and neck cancer surgery, and I'm not practicing the orthogynec. So routinely for peripheral nerve blocks, and I am out of the questions. So all this general anesthesia regarding all this urology surgery also I am doing under general anesthesia, even PCNL, URS, everything except TURP.
Yes.
So all my ENT surgery, all my laparoscopic surgery, all my urology surgery and pediatric surgery, I am doing under KPD or either dexmedetomidine or either. See, I will see with the tailor-made anesthesia. Suppose my patient is having 3 hours of surgery for commando and flap surgery, then I'll put on my patient with the dexmedetomidine infusion, not with the KPD infusion.
Okay.
So I will decide myself on the table of every time. Each and every patient is different then, but TIVA is there only, and I am using frequently. See, how I am giving also one of the good way of telling you answers. First drugs, first 100 ml of paracetamol drip is going with my patient with 1 ml of Dynapar, means diclofenac sodium, mixing with that paracetamol. First pint, then I start ringalactate. Then in that ringalactate, it will be finished in the ward only. These 2 drugs will be given in the ward. At least 450 ml of means whole the pint will be completed in the ward. That patient comes in the OT. Then I start the oxygenation at least for 5 minutes. I am combining DML mixture. DML means mixture is a dexmedetomidine or a dexamethasone, magnesium sulfate, and xylocard mixtures. That is 2 ml of this magnesium sulfate. Then 2 ml of Dexona and at least 3 to 4 ml of xylocard, and that is 1 milligram per kilogram. Then I mix it. It is viable. These 3 combinations are viable. We have tested. There is no crackling. There is no gas bubble that can be used within 6 hours after mixing it. After 6 hours, the efficacy will be reduced. Not the drug will be separated and there is a precipitation like that. So these drugs I am giving very slowly to the patients when we are doing oxygenation. Then I start with the KPD infusion or a KPD inductions or propofol induction or dexmedetomidine, whatever it may be. It depends upon. Then scoline, then switching over the infusion and this infusion. And I put my patients on the base. And probably I put this propofol syringe in 10 ml syringe in between. And suppose my base level goes more than 50 sometimes, then I give 5 ml of propofol bolus dose. So these are the routine practice. One thing is that esmolol, I am using frequently with esmolol because all the way people are they are having a perception that esmolol should be kept in when patient gets hypertension or something tachycardia. But my way of doing is that whenever the patient's tachycardia goes more than 90, or if the patient's BP goes more than 120, always use this esmolol. It's a very short acting drug. At least you give 2-3 ml, then patient will be settled down. You do not wait that if it goes more than 150 blood pressures or it goes more than 100 of tachycardia. At that time, then there is a, see, you can reduce only up to, if blood pressure goes 150, then you give, then it goes up to, comes up to 120.
To take a time.
But before that.
Yes.
So this is my routine practice. And at the end of using for extubation, always combining with lidocaine with neostigmine and glycopyrrolate. And no doubt, there is no use of midazolam, narcotics or something like, ondansetron, one dose is given. And this is routine for every day, 3 to 4 laparoscopic surgery or 2, 3 ENT surgeries. And since last 20, at least 15 years, there is no major problem. So that is why now I have started a TCI-TIVA practice with propofol, and I'm waiting for that remifentanil, because see, now Acromed company, which we have done first TCI-TIVA workshop in Coimbatore last year. At that time, more than 50 delegates were there. And at that time, Acromed company has launched in South India one TCI pump that was around 2 lakhs rupees. It's a general purpose model pump. And now this pump is available all over India. So this pump is very good blessings for us. But the only thing is that here we are using, why I have to shift over this manual dosing, why I have to shift with the combinations, because remifentanil I am waiting since last 10 years in the market. Still the remifentanil is not available, and only propofol is not going to give a very good anesthesia. You have to combine with either ketamine, dexmedetomidine, or some narcotics or something like other agent. So I have again thought that which type of the TIVA will be beneficial to people. So I have started since last 10 years this, and now I am doing off-TIVA practice, opioid-free TIVA. That is also. Okay. And now when the remifentanil will come, then I will again use narcotics. But dexmedetomidine TCI-TIVA is also now available in the thing is that one thing is very bad for the US people, that TCI-TIVA is not FDA approved in USA. So they are not using TCI-TIVA. Only European countries and Asian countries are using this TCI-TIVA. So their TIVA practice is like what I am doing this practice. And T-cell. So hardly in my area, at least if I say that in Vadodara, hardly 3 to 4 people are using TCI-TIVA. Otherwise, people are using only TIVA practice. Even in Nanded, I don't think is there any people having a TCI pump.
No, so we don't have any pump.
No, sir.
Yeah, that's what I am telling. Because it was started just 2-3 months back.
Yes, sir.
Now again, we are doing some national conference in Shillong. Also, we are doing TCI-TIVA workshop.
Yeah.
So you people are welcome there.
Satish, please take question. Sir, there are
some
4 to 5 questions
are
in
there.
Q&A box. Please see.
So one question is
please.
from Karuna Patil, that is she has asked for the skin, how to use in skin patients. Yeah, the skin patients, I had got my skin specialist, mostly he's calling for the warts removal in the pediatric patients, where he goes for the 10 minutes to 15 minutes procedure. So I'm giving dexmedetomidine ketamine combination, that's simple. 1 milligram, 1 microgram. And I'm using ketamine, dexket combinations for my patients. I'm putting oxygen on his table only, and suction machines and everything is, anesthesia cart is ready with me. So it is very simple. Second question, sir, excellent technique. What will current chances of can PCM be mixed with diclofenac? Yes, PCM can be mixed with the diclofenac. You know that diclofenac tablets is also available. If it is orally mixing, then IV mixing is also there. Even now, combiflame is means this ibuprofen. Ibuprofen is also available.
Injectable.
Yeah, injectable is also available. Pump. Yeah.
Yes.
Propofol dilution if used in a drip, especially if no syringe in pump. I have told you in my that how to dilute it. 1 part of the propofol and 4 parts of the dilution. So that is the way we have to use. Are you not using any other relation than scoline in HNF surgery also? No, I'm using scoline is for the only intubation purpose. Otherwise, I'm using cisatracurium for my long surgeries. Scoline is only for the induction for intubation. That's all. Otherwise, 1 dose of scoline 1 to 1.5 milligram per kilogram for the intubations or IGL. Sometimes even I put IGL under KPD anesthesia. That is also very good way. Yeah. So I think I have completed all these questions.
Yes.
See, PCM
for IGL point of view or no? Can I ask one question?
Yes.
Sir, you said you said IGL you used in some cases, or sometimes you don't use any airway also. Which procedures you do like that? Please, can you elaborate on that?
Oh, so many procedures for 10 minutes of procedure. for 10 minutes for the removal of
So,
the foreign
no,
bodies.
so, uh,
Okay,
See,
removal of foreign body.
see,
yes, sir.
for,
Because this
for
is a private forum
colonoscopy,
point of view, I am
see,
asking. So people
yeah,
will.
that's what I in NORA situation sometimes foreign body removal, then colonoscopy, endoscopy, then sometimes under examination of ophthalmic anesthesia. Then I'm using for the, I'm not doing gynec and orthopedic, but I'm using for cystoscopies. I'm using for the optical urethrotomy. And when, see, the thing is that you have to make it possible that each and every patient you have to examine and see that this patient is under, when you are giving this single dose without any airway, then when the patient is snoring, then you put nasal airway, that's all. In between you can decide it. But most of the time I put like this head, and for 5 to 10 minutes, nothing is going to be happen.
Okay.
Sir,
Okay,
about Nora, about what I wanna ask you. Can
Non-operating
you please
room.
elaborate on that? Some.
Non-operating room anesthesia.
Yeah.
yes, yes, sir. Yes, sir.
Non-operating room anesthesia I am doing mostly in the gastroscopy room. That is for the colonoscopy, ERCP, and gastroscopy, and sometimes polypectomy. At that time, there is no, at least I'm working with 2 gastroenterologists in Baroda, and they are the leaders in our area. And more than, I have written a paper of 10,000 colonoscopies under TIVA just 3 years back. So most of the time I have used this technique, and my basic thing is that you know that as an anesthetist, when the patient is lateral position, then the airway is very good for us when patient is in prone or supine position. So that is naturally for colonoscopy or endoscopy or ERCP, the procedure lasts for at least half an hour in ERCP, 10 minutes for the colonoscopy, and hardly 1 or 2 minutes for the gastroscopy. And I'm not taking that patient deep anesthesia, but something sedations and little bit analgesia under ketamine and this KPD. So oxygen is full oxygen is going on. So there is no doubt that I have to put a nasal airway or oral airway. Oral airway out of the question because we cannot share with the gastroscopy is the same oral mouth. But sometimes in ERCP, what I do that I have gastro LMA. Gastro LMA means gastrolaryngeal mask airway, where there is a 2 port. One port is for the IPPR and one port is to introduce the scope, endoscope. So that scope, when I use this, I put patient in the KPD anesthesia, I put a LMA, gastro LMA. Then this sometimes this procedure lasts for even 1.5 hours. So patients are very much safe under this because I have like intubation. It is available at 22,000 rupees, but it can be repeatedly used.
Yes.
And for colonoscopy or for polypectomy, pediatric patients, Dexcate, ketamine, dexmedetomidine. I was using propofol ketamine just 5 years back in all patients in pediatric, but now I have switched over to dexmedetomidine and ketamine. Excellent result in pediatric anesthesia.
Yes, a wonderful drug. I am also using.
Wonderful drug. I'm telling.
Yes. Sir,
you must start using Dexcate.
Really, sir. Sir, I wanna ask you on ECP and poems. Poems generally do some our gastroenterologists. And what type of means I wanna elaborate about that ERCP and related to ERCP TIVA.
ERCP TIVA, I have told you.
How you?
I have written a one
power.
I have done a one PowerPoint presentation. If I can share, then you just give me the. I will share you one PowerPoint for 5 minutes. Can you give 5 minutes for me?
Yes.
Hello.
Yes, yes.
You can.
Yes.
Definitely.
Yes,
sir, before that, one question from our treasurer MSCISA, Dr. Samir Sohni, sir, is asking in chat box. Please, Satish, take this question. MRI suit use of TIVA.
I'm not doing practice of this MRI. But MRI same will be done this with MRI. Nothing to worry. I can use. See, MRI does not require analgesia. So you can give dexmedetomidine sedation, or even pediatric patient you can give low dose of the Dexcate solution. Instead of 1 milligram, you can use it at least for 0.5. So you can see the anesthetic management of ERCP patients in high risk patient. Can you able to see my slides? Hello.
Yes, yes, we can.
Okay, I'll
Yes,
go,
sir, we are
I
able
will go very fast way. How I am doing?
Yes, yes.
Just a minute. Just read. I am not speaking, but just go on reading. In between, I will tell you how I am doing.
Yes, yes.
You know endoscopy, how it is done. What are the indication, diagnostic, therapeutics? Then ERCP contraindications. Then ERCP procedures room layout. This is our own room. How we are doing in our Baroda. Then these are the endoscopy procedure room where how the patients are living. We are here as an anesthetic. We are having anesthesia card. We are having a CM endoscopy care. The gastroenterologist sits here. Right? And patient is to be like patient, patient is to be tell like this in preoperative period, how to prepare smoking, tobacco prohibited, current medication to be continued, removal of denture, jewelry, then other things. Then positioning during ERCP. Usually we are doing in the left lateral position under semi-prone. So this is the way we are doing. Right? So these are the lateral supine positions. These are the way ERCP is done. This is also one of the positions we are doing. Left lateral decubitus position is most common. And one of the this Vortex company has came with a 50,000 rupee new endoscopy positioning system. Here you can put your hand like this. I have not seen, but the Oxford people have invented this system. That is called endoscopic positioning system. So patient receives local anesthesia or sedation or general anesthesia for ERCP, right?
Yes.
Then patient lies on their back. Flexible camera is inserted. Here, what I'll do, I'll say that once the gastroscopist is ready with their ERCP camera and scope, I give little sedation first. Once they introduce their camera and they go in the gastric antrum and then duodenum, then I give more sedation, because first if I give sedation more, then patient is uncontrolled. So that is the way, like routine, for routine gastroscopy, the sedations are not required. So something like that for oral anesthetic spray is done, and for introducing of the scope we are giving. But after some introduction up to the second part of the duodenum, seeing the water ampulla and the sphincter, then we are giving more sedation, and the patient put on the all the monitoring with ETCO2 and everything. Like,
yes.
So, and when sphincterotomy with electrifier, Goldstone's, these are the procedures how they. So after the procedures monitored for the endoscopy room for 1 to 2 hours. And my rule is that all ERCP procedures should be come with the, we should give the intravenous fluid. Otherwise we don't do, because sometimes what happens, they use this Buscopan very frequently. That gives a gastric distension. So at that time patient gets pain and the patient is prone position. And sometimes there is a patient's discomfortness is there. So you must be careful on that part also. Now monitoring is oxygen, heart rate, capnography, SpO2, everything is. The thing is that I always tell my gastroenterologist, just 2 years back, I was able to convince him that you should have defibrillator in your room. Because once in a while, ERCP patients can die on table. Believe me. Because of the oversedations or because patient is prone, and there is always there is a hypoxia. Whenever there is a introduction of the scope and there is a procedure is going on, you will see that your oxygen level is going down. So be careful on that part. So goals are ERCP is uncomfortable procedure. Sedation during this procedure is often deep. Patient cooperation is an imperative factor. Anesthesia analgesia is also very important. Desaturation remains the most observed adverse effect, right?
Yes.
So what are the different anesthesia techniques? I use these techniques. Local spray, anesthesia with special gastrolaryngeal tube, local spray with IV sedation, local spray with IV anesthesia agent with intermittent dose with or with TCI, and anesthesia with oral or nasal endotracheal tube. Sometimes I have to use endotracheal tube in my pediatric patient also. I have done up to 7 years of age of ERCP. So I have to intubate at that time.
Okay.
So these are the journal articles are very much good articles. And these are the things are available. Some things OxyGuard, that is oxygenating mouth guard. And this gives a very good mouth opening. This is also penis mouth guard. One is for the lips and one is for the capnography. One is for the attachment. These are the VBA endoscope. From this you can introduce your fiber this scope. And these are the gastro LMA. These are the gastro LMA available now in the India in Bangalore company. When somebody gives in 22,000 rupees. And this is both LMA gastro LMA and this 22,000. Yeah. And pediatric ERCP, you just remember two things. They are prone to desaturation and bradycardia. Now, how I manage my patient? High risk patient for ERCP means CSA2 with active. Most patients were more than 50 years old. Youngest were 18 years.
18 years.
Just a minute, I have a phone call. Hello. Hello. Okay. Okay. Connect. Okay. Hello. Sorry. So in last 28 years, I completed more than 500 SAP. So by ERCP anesthesia in high risk, first 8 years conscious sedation plus Buscopan, second 10 years propofol sedation plus Buscopan, and third year Buscopan will taken over by ketamine, so KPD.
Okay.
So all three phases I have used. My standard protocols. ERCP is very much every weekly I do at least 6 or 7. So not every day, but we are having a Tuesday and Friday the fixed day for ERCPs. But believe me, I have lost 2 patients in my lifetime only because of ERCP, and in my all anesthesia armamentarium, I had given more than 70,000 anesthesia and 2 patients on table death not because of anesthesia, because of patient condition, and that is only with ERCP only. So I'm very careful about ERCP, and my lesson to life is that they don't take ERCP anesthesia lightly. Always I give 2 hours to that patient, even post-operatively also with them only. That is the way.
Okay. Yes.
Okay.
Yes, sir. Yes, sir. Yes, sir. Okay. I think you are in a hurry, sir. I have a very nice. Very nice.
Last question from Dr. Shashi Patil, sir. Sakish. In chat box, Sakish, in chat box,
yes, sir.
Shashi Patil has asked a question. Please take it. He is the secretary of ISA Latur branch.
Yes.
I'm audible, Satish?
Yes. Please. Can we use TIVA for major surgeries with intubation and muscle? Yes.
Yes. And then
sorry, Satish.
No problem.
Because time has gone far. So this is the way I am doing this job. And
yes, sir.
Thing is that. Okay, you have any questions?
Yes, sir. One question. Can we use TIVA for major surgery with intubation and muscle relaxation?
That is what I told you. I am doing SRS surgery, sex reconstructive surgery from male to female. That lasts for 8 hours. 8 hours. So I have done more than 50 patients in last 5 years, and this is the only center in Gujarat where we are doing as a teamwork as a plastic surgeon, neurologist, vascular surgeons, and everything. So I am doing with IGL only. That is with the dexmedetomidine infusion and for KPD. See, these are all young male patients around 25, 30 years. So at least for 7 to 8 hours, no doubt, I have to give general anesthesia with this muscle relaxation, but I have switched over from atracurium to cis-atracurium. That is the way. I'm not using now atracurium because newer drugs are very good. Cis-atracurium is better than atracurium. So that is the
Yes,
way.
yes.
But for 8 hours, see, people have used in cardiac TIVA. One of the anesthetists, Kalpana Shah in Bombay, that is in Bridge Candy Hospital, I think she has used more than 10 hours of intra. Even in Bangalore, people have used in Neuro TIVA more than 12, 14 hours with TCI TIVA. So there is no doubt that TCI TIVA, we can use even hours together, nothing to worry. Because this is like a switch on switch of anesthesia. Once you put off the TCI pump, then pump will tell you that the patient will come out within 5 minutes, within 7 minutes. That is the beauty of this TCI TIVA and even this TIVA. No doubt, I am not against the inhalation and technique.
Yes.
Sir, ask for question. You are waiting for almost for 20 years, I think so.
Sachin, I am not able to.
Sachin, yes, sir. Sachin, right now we are not able to listen you. Hello.
Okay. I want to ask one question on that.
Sachin, can you write it down?
Sorry. Yes. You can write it down.
I think I have fulfilled my criteria about telling all this TCI, TIVA and TIVA with my all this practically. See, why I am doing this TCI, TIVA and TIVA canvassing all over India, because I am only anesthetist in private practice doing this job. Otherwise, if you go to all the way in all over India, then people are using in corporate hospital, people are using in their government hospital. But this Nanded people, I think they are most of the private practitioners. Am I correct? Hello?
Yes, sir.
Okay.
So, once we get the question from Sachin, I will mail you or get answer for the question.
Sir, I'm really worried about fentanyl. As last Wednesday day, we are introducing fentanyl to our members. It is easily available for us. And you are happy with remifentanil. What is the difference on that fentanyl, remifentanil in TIVA?
In TIVA, now fentanyl is outdated drug. Remifentanil is very short acting drug. Remifentanil is very short acting drugs. Once you give any very good recovery, I think remifentanil and fentanyl पे बहुत फर्क है. I think you can go to my infographics here. What is the difference between fentanyl and remifentanil? Once the remifentanil will come, then hello.
Actually, I want to ask this question on that note. You are very much eager to hear from pharma companies when remifentanil come in India.
See, I was told by the Neon company, Troika company, Varanium, and other flagship company.
But when fentanyl is available in actually fentanyl is available in market, you are eager to give remifentanil. What is the main? I want to reason that only to our practice from that we are using fentanyl in our backward area. So be careful of that. So I ask that question only. That point of view.
Sachin, we are not getting your question correctly.
I think Sachin, you ask me personally. I will tell you. Don't worry.
Yes. Sachin will ask you. Yes.
So can we close this meeting now?
Yes, sir. I am very thankful, Choksi sir, for presenting the nice topic, and I hope all the people who have enjoyed very well and use your techniques we have supported or given ideas today. Thanks a lot. Thanks very much.
Second thing, Satish,
yes,
I will give my all these PowerPoint presentation slides to you and Dr. Sachin and my infographics and everything. So you can have all these things and you will be okay. So you give me your number also.
We will be in contact. Yes, I will provide you.
So I am leaving now.
Thank you. Thanks a lot. Yes, sir. Okay, definitely. Thank you. Thanks a lot, sir.
Thank you a lot.
Sachin.
Thank you, sir.
Thank you, sir. Thank you. Yes, sir. Thank you, sir.
Yes, Satish.
Yes, we can close the seminar now. Yes, sir.
I'm really
Thank
in
you.
remote place, so I'm not able to conduct this.
Yes.
But
Yes,
sir,
yes,
I will
yes, sir.
talk to you in personally after that.
Yes.
So
Yes,
I will
yes.
conclude this session. Please, Satish, conclude this.
Yes.
Sir.
Yes.